Today we'll be discussing about the retromolar trigone. So what is retromolar trigone? So from the name itself, retro means behind, molar means the molar tooth, trigone means triangle. So it is a triangle behind the last molar. So retromolar trigone. According to AJCC definition, that is American Joint Committee for Cancer definition, retromolar trigone is an attached mucosa or a triangular shaped mucosal fold present in the ascending ramus of the mandible, extending from the posterior part of the last molar that forms the base to the apex pointing superiorly adjacent to the maxillary tuberosity. So it is here, triangle forms like this. See, this is how the triangle is seen. So here the molar, then this is the lateral boundary, this is the medial boundary, and then the apex is pointing towards the adjacent to the maxillary tuberosity of the upper jaw. That is how the triangle is formed. So the base is formed by the posterior or distal aspect of the last molar or the third molar. The medial boundary is the mucosa that is continuous with the anterior pillar. So to exactly differentiate the medial boundary, if you draw a line from the lingual cusp, so the molar will be having 4 cusps. So if you draw a line from the lingual cusp to the coronoid process of the mandible, that forms the medial boundary. The medial boundary merges with the anterior pillar. The lateral boundary, if you have to delineate, if you draw a line from the oblique line of the mandible joining to the coronoid process, that forms the lateral boundary of the retromolar trigone. The lateral boundary is continuous with the buccal mucosa. And the base is formed by the posterior part. No? So the base dips on both sides. So inside, medially, it is continuous with the gingivo-lingual sulcus. So the tongue is there. So gingivo-lingual sulcus. Laterally, it is the buccal mucosa is there. So the base is continuous with the gingivo-buccal sulcus. So that is very simple. That is the boundaries of the retromolar trigone. So what is the mucosa of the retromolar trigone? The mucosa of the retromolar trigone is the same as the buccal mucosa, that is stratified squamous epithelium. And the mucosa of the retromolar trigone appears to be slightly thicker than the buccal mucosa. And at the angle joining two alveolar arcades, it is slightly elastic so that it allows for the jaw movement. What is the blood supply of the retromolar trigone? The blood supply is from the ascending pharyngeal and tonsillar arteries, and also there are contributory arteries from around the oral cavity also. The venous drainage is into the tonsillar bed into the common facial vein. The nerve supply is mainly from the mandibular nerve, the buccal nerve. Also, there is a supply from the glossopharyngeal nerve, because that is why if there is any lesion of the retromolar trigone, you can get a rhabdotalgia due to the common nerve supply. What is the lymphatic drainage? The lymphatic drainage is into the level 1 and 2, upper jugular nodes and also submandibular lymph nodes. Just below the retromolar trigone mucosa lies the pterygomandibular raphe. So the pterygomandibular raphe is the tendinous fibrous bands that connect the pterygoid hamulus to the mylohyoid line, and it gives attachment to the buccinator muscle and the superior constrictor muscle. Further laterally, it is related to the masseter and the anterior border of the ascending ramus of mandible. Retromolar trigone clinical significance is it is an anatomical subsite for oral cavity cancer. So the oral cavity is divided into 8 anatomical subsites to be precise. What are the other anatomical subsites? The anatomical subsites are mucosal lip, upper alveolar ridge, lower alveolar ridge, buccal mucosa, floor of mouth, anterior 2/3 of the tongue, hard palate, and the retromolar trigone. These are the 8 anatomical subsites of the oral cavity. Because it is a very small anatomical site, any lesion occurring in the retromolar trigone can easily spread to the other subsites like buccal mucosa, or can involve the oropharynx. It can spread to the other region faster, and usually the patient presents later. It is not a very common site for oral cavity cancer. It's 6 to 7% of the oral cavity cancers occurs at the retromolar trigone. But when the patient presents, it is usually at a later stage. So stage 3 or stage 4. That is the main significance of retromolar trigone. The cancer can spread into the lateral border of the tongue. Then it can spread into oropharynx, the tonsillar bed. It can spread laterally into the buccal mucosa, the buccal pad of fat. The cheek can be involved. It can involve the masticator space. So what are the contents of the masticator space? The masticator space contains the muscles of mastication. That is the middle pterygoid, lateral pterygoid, masseter, and temporalis muscle. So four muscles. Then you need a nerve to supply. So the nerve supply of the masticator muscles are from the mandibular nerve. So you have the mandibular nerve. Mandibular nerve enters the masticator space from the foramen ovale. Then you have the arterial supply, the branches of the internal maxillary artery, the venous drainage, the branches of the pterygoid plexus of veins, and also the bony mandible. Most of the body and the ramus of mandible. These are all the contents of the masticator space. This can get involved and also related to multiple nerves. The mandibular foramen, the inferior alveolar nerve, the lingual nerve, inferior alveolar nerve and the lingual nerve are branches of mandibular nerve, and also mylohyoid nerve is a branch of inferior alveolar nerve. All this can be involved in a cancer of the retromolar trigone. Usually squamous cell carcinomas are not neurotropic. That is, they do not spread via the nerve. Usually they do not have a characteristic to spread via the nerve. But retromolar trigone squamous cell carcinomas can involve this nerve and have a tendency for perineural spread. You have to keep that in mind. Also, the retromolar trigone can involve the bone, the maxilla and the mandible, because the apex point towards the maxillary tuberosity. So certain studies show that the posterior maxilla is more commonly involved than the mandible. And also the problem is with imaging. With the contrast CT and MRI, the cortical bone involvement is very difficult to diagnose. Like there is no negative predictive value that if there is no involvement, we cannot say that the bone is not involved. During surgery, we have to do with the periosteal stripping, we can identify whether there is involvement of the periosteum, because the periosteum will be involved initially before involvement of the cortical bone. The bone involvement is more common in edentulous patients. The bone involvement is more common. Also, involvement of the masticator space or the lower pterygoid plate is T for B stage of the retromandibular cancer. And the patient presents with rapid ear pain and also trismus. If trismus is there, it means that the pterygoid muscles are involved. So that is why the lateral pterygoid is involved. That causes trismus. Retromolar trigone carcinoma can also involve the sublingual space and the mylohyoid muscle. What is the treatment of a retromolar trigone cancer? So the primary treatment is usually resection, surgical resection with pre or post-operative radiotherapy or chemoradiotherapy. Radiotherapy alone to treat retromolar trigone carcinomas has shown to have a higher recurrence rates. For very small tumors, you can use a transoral resection technique. But the resection has to be achieved with 1 centimeter margin in all directions. So most of the cases, larger tumors, you will have to do a cervicofacial incision with mandibulotomy, parotidectomy, and with or without zygomatic osteotomy. So how do you decide whether to do a segmental or a marginal mandibulectomy? So a marginal mandibulectomy is done if there is no cortical bone involvement. A marginal mandibulectomy is done, and if patient has not received any previous radiotherapy or anything, a marginal mandibulectomy can be done. But if the patient has received a previous radiotherapy, you have to always go for a segmental mandibulectomy. Or if there is a cortical bone involvement, you have to go for a segmental mandibulectomy. And if you are doing a mandibulotomy, so mandibulotomy with marginal mandibulectomy, if you do, there's a chance of poor healing. So if you're doing a mandibulotomy, better to go for a segmental mandibulectomy. So for large tumors, you have to go for a segmental mandibular resection only. And for reconstruction in retromolar trigone area, because it is so much inside, so the usual myocutaneous flaps that we use, pectoralis major myocutaneous flaps, can be too much stretched and there can be delayed healing. So you can use free flaps like radial forearm free flaps or anterolateral thigh flaps. Reconstruction will give excellent healing. If soft palate is resected, you can use a free flap plus a superiorly based pharyngeal wall flap to prevent any nasopharyngeal insufficiency. After segmental resection of the mandible, vascularized bone flaps are recommended, like fibula flap, DCIA flaps, or scapula flaps, because most often after segmental mandibulectomy, the patient will require a radiotherapy. So to prevent non-union or necrosis, it is better to use vascularized bone flaps. How do you treat the neck? Usually the involved nodes are the level 1 and level 2. Sometimes level 3 to 5 can also be involved if level 1 and 2 are involved. So if the tumor is more than T1, always an elective neck dissection is done for retromandibular cancers. And another clinical significance of retromolar trigone is it can be used as a landmark for giving local anesthesia to the inferior alveolar nerve block. in certain patients with there is blood dyscrasias and all that, the local anesthetic can be directly infiltrated into the retromolar trigone and it will go via the ports into the mandibular foramen area. And so the local anesthetic can be infiltrated in the pterygomandibular space so that the nerve is anesthetized before it enters the mandibular foramen.